Hi, it's Rick again. I just want to talk to you today about some biomechanics, and we're going to look at some other muscles of the lower leg. And we're going to try to keep it real so you can kind of see how it would work as far as thought processes. We'll go through some palpation, and ultimately this will be a little series of videos that will basically kind of show you what a session would look like, and it will be in a series of videos. So first thing I wanted to talk to you about with running, a lot of times, very often what you see with runners who end up having some pain at some point is that the forefoot is supinated. Really common. You don't always see it when the foot's on the ground. You might see that big toe hover off the ground slightly, but then when you flex the leg at the knee joint and you have them in a position of plantar flexion, you see that forefoot is supinating. And ultimately that's a problem if you think about timing, because the brain knows that you have to get to the big toe. So if you think about that, the foot's coming into the ground, ultimately it's a position of plantar flexion. So plantar flexion of the leg at the ankle joint. Okay, so it's the relationship of the leg and the foot, and that's really important because we want to be able to get to that big toe. And if you think about somebody that's landing on their midfoot, forefoot, they really are going to get to that big toe faster, but it's kind of relative, because if they don't have stability, the brain might not want to go there right away. So we really want the brain to sense that stability through the forefoot so that you can get to that big toe faster. So what we're going to do is we're going to improve the mechanics. You'll be able to see that. We're going to have more range of motion, but at the same time we're going to have more stability. Okay? So I'm going to start with Peroneus longus first, and then we'll go from there based on what we see. So the first thing I'm going to do is I'm going to start with, again, going back and finding the head of the fibula. And then we're ultimately going to work down the lateral aspect of the fibula, but at the same time we're going to get up underneath this posterior aspect of the fibula. So if you look at a cadaver, you'll see that the muscle doesn't just lie on the side of the fibula here, or the lateral side, it actually wraps around to the back. And the books don't always show that very well, and very often they don't even say that. But that's really important, is if that muscle wraps around the bone, it's going to play a huge role in the transverse plane. So one of the things the anatomy book doesn't say about Peroneus longus is it will actually laterally rotate the lower leg. So that's really important. It's going to laterally rotate the lower leg, and that's going to be more of a supination, but it's ultimately going to change transverse plane motion up at the knee. So that's something we really want to look at. Okay, so I'm going to put this here, and then we're going to just put it, just to keep the palpation a little easier. Just bend your knees for me, and I'm going to just throw a bolster in there. Perfect. Okay, so we're just going to first of all find the head of the fibula, which is right here, and then we're going to come in from the side. So my pressure is this way, and I'm going to follow the fibula down. So I'm compressing the tissue into the lateral aspect of the fibula at this point. And then you can see this is going to be more of a transverse friction. There are times where I'll use more of a circular friction, so I'm doing that right now. So I'm feeling for the lateral aspect of the fibula and just following that Peroneus longus down where it attaches to the fibula. And just like all the other things we've talked about, this can be sensitive. A lot of times the person doesn't even know it was sensitive because nobody's ever worked at the attachments. So the key here is it's not what you do, it's how you do it. So we're going to improve the mechanics, improve the stability, and ultimately the brain will feel more comfortable going to that big toe. And if you're familiar with Peroneus longus, it plays a huge role as far as the big toe goes. It's attaching to the base of the first metatarsal and the first cuneiform. So it plays a huge role when that foot comes into the ground. So I'm trying to get a little deeper here. Just kind of fine tune my palpation a little bit now that I've been through one time. And I'm still focusing on going into the lateral aspect of. By flexing the leg at the knee joint here, we'll actually be able to go into the posterior aspect as well. It'll be easier to do that. You can do this sideline too. That works out pretty well. So it's good to be able to palpate muscles in different positions, because you never know if the client, they might not be able to lie on their back because they have back pain. Okay, so we're going to follow this down. And then I'm going to go right up into the back of the fibula as well. So I like to go through one time, kind of get a sense of how the tissue feels, kind of the pain tolerance of the client. And you get to the point where you can pretty much feel when it's, closer to a 10, just based on how the tissue feels. Okay, so now I'm going to go back to the head of the fibula, and I'm going to get under the posterior side there. Okay, so we're going to go right up under or into the back of. So I'm at the head of the fibula here, or just distal to the head, and now the focus is going to be up into the posterior aspect of the shaft here of the fibula. So this is definitely more sensitive through here. And like many things, or many areas where we're palpating the attachments, there'll be a decent amount of burn here too. So you might have the client feel that as well. Again, more sensitive right through here. And so another way to say that is, if there's inflammation here, that will eventually be a problem because the person's compensating. So he might be a successful runner, and then all of a sudden he has pain. Well, that's been there for a long time. It's just your body was able to adapt. And then maybe you twist your ankle, stub your toe, it could be anything. And now you start to compensate differently. And now you have pain. Okay, so this is pretty good here. The only thing I'm going to do before we finish our palpation here is just going to go back. I'm going to move closer to his foot and change my angle and its relationship to the knee. So I'm just going to move closer to the ankle. And I just want to show you real quick. Once you find the head of the fibula, I recommend going up into it. So I'm pushing in, of course, but also up. And I find that really helps you to get more transverse plane motion. The better your palpation, the better results you're going to get. Because ultimately, we want this muscle to hold. So this isn't like, wow, this is going to feel good for 24 hours. if he wears a flat shoe or walks in his bare feet for 48 hours, wears a minimal shoe, something flexible if he has that, this will make a huge difference on his running mechanics. Okay, but if he goes and puts a stability shoe on or anything with a lot of arch, we can blow that out neurologically. So that's really important. So I tell all my clients, give it 48 hours, keep your foot in an environment that's flat, and then you can get back to your running. Okay, so I feel good about right through here, and of course as I'm going in and then up, that's going to be more sensitive for the client. So again, it's really about precision, and your direction of force makes a big difference. Okay, so that's going to make a big difference there. And now I'm going to go down to the big toe. So we know that Peroneus longus comes behind the lateral malleolus here. Okay, and then ultimately it's going to come back behind the base of the fifth metatarsal here, and then it will come over to the base of the first metatarsal and the first cuneiform. So the way I palpate that, similar to the way I would palpate tibialis anterior, is I'll take the foot and I'll do a little inversion, and I feel for the sesamoid bone or sesamoid bones, and I'm going to follow the shaft of the tibia back, and I feel for the base of that first metatarsal, and then I'm going to come onto the medial side, lateral side of the base of that first metatarsal. And you can see that here. So again, a slight inversion, pressing into the foot, and then my pressure is going to be up and into the base of that first metatarsal. So compressing the tissue, and this is definitely pretty sensitive here. I would say that pretty much everybody is sensitive right through here, especially when you're not afraid to get right in there. And you'll feel the tendon as it comes right into the base of that first metatarsal. Okay, so a lot of times that first metatarsal takes a beating. We don't even know that there's inflammation in there. Okay, so I'm just going to move slightly lateral here, and now I'm going to change. My pressure is going to be more this way for him. Okay. So we're compressing, and then right into the base of that first metatarsal. Okay, now I'm going to follow right on to the plantar side. Make sure we get it there, because ultimately we know that the tibialis anterior is going to come around and meet the Peroneus longus. So the tibialis anterior and Peroneus longus form that stirrup. And of course that's going to help to stabilize and support that arch. Okay, so now I dropped off onto the cuneiform, and my pressure again is of course towards the foot to get the depth, and then I'm just compressing the tissue into the lateral side. This is going to be real sensitive here. The lateral side of that cuneiform. And then I'm going to get right onto the plantar side And then ultimately I like to get right between those two bones. So right where the two bones meet or articulate, which of course we would call a joint, I like to get in between there as well. Okay, so we go back and we check range of motion. I'm going to have you bend your knee there. Okay, you'll see here, and I didn't show you this before, but this big toe is now sitting flatter. If we compare it with the other side, I'm going to have you bend this knee. You can see, if you look probably from this angle, you can see how this is up more and this is down more. Okay, and we'll start to see more here as we look, but you can see that that forefoot is slightly supinated on this side, and on this side it's not, because now that big toe feels like it can actually do plantar flexion. So it feels comfortable lying flatter. And that was a pretty big change from what he originally had. And you actually could see that in another video that we just did for the TFL. Actually, you could see his right foot and how it was sitting. So again, supination through the forefoot here. That big toe doesn't really want to get down to the ground. Here you can see it's much flatter, and we'll start to improve on this even more. Okay, thanks for joining us today, and we'll have another video for you soon.